Evening. I'm sure you're all saturated with Zoom meetings, but hopefully I'll try and make this as interesting as possible. Bodine's given me a topic on knee osteoarthritis to cover. I'll just start with a screen share. Hopefully this works. If you have any questions, just fire them across. I'm reasonably good at answering them as we go along, or we can save them for the end, whatever you prefer. Hopefully you can all, oh, what's happening there? Good. Can everyone see that? Bodine, we okay?
Yep, we can see that.
Perfect. Okay, I'll make a start. So as you're all aware, the Southwest Elective Orthopaedic Centre is a partnership between Croydon University Hospital, Kingston Hospital, Epsom and St Helier and St George's Hospital. So we have a group of surgeons that come across and operate at the EOC. Some of us spend more time there than others. My background is that I'm a specialist knee surgeon, as Bodhi's pointed out. I am the joint director of surgery at Swellyock. I also serve on a number of national committees. I'm on the SICOT Sports Knee Committee, and I've been serving them for a couple of years. And in the past, I've done a lot of work with ESCAR and locally or nationally or with the National Orthopaedic Alliance. My practice is predominantly sports work. I had 70% sport, 30% arthroplasty work. I have quite a complex practice, and I do a fair amount of second opinion work, particularly on knee instability work. But my interest has really grown in the arthritis side of things over the last few years, and thinking about how we can make things better for our arthritic patients. And so the aim of this talk is really to give you a little bit of an update on our centre, give you my approach to managing knee arthritis and what I call the 5-step approach, and address some common questions such as red flags, conservative management prior to referral, some of the boring ECI criteria. It's important to look at, but it is relevant in terms of making sure that appropriate referrals are sent across, and a little bit on diagnostics as well. So Swellyock, we're a centre of excellence. We're a partnership, as I've pointed out. So really you can refer to any of those hospitals, and it's best to refer to the local one, and your patient will have their knee replacement done at or hip replacement or their partial replacement done at Swellyock if they need it. And Bodine's done some phenomenal work on creating consistent pathways between the centres so that the care is very synchronised and smooth. Swellyock will be opening a new theatre later this year, and so we'll have capacity to do even more. We do about 3,500 to 4,000 joint replacements a year, which makes us the biggest centre in the UK for joint replacements, probably the biggest centre in Europe. So getting on to our topic of knee osteoarthritis, as you're all aware, it's a common problem as we get older, but we're seeing a massive growth in arthritic patients in their 40s and 50s. I've been operating all day today. I had a 34-year-old with a very arthritic knee at Croydon today, and I've done something unusual in her called a biopoly. So we're seeing a challenging group, young patients becoming arthritic, and the demand is growing, and patients want to remain active the older they get. I've got patients who are running in their 70s now, and so that poses challenges for many traditional treatments. All too often, a diagnosis of knee osteoarthritis equals a total knee replacement, and things have moved on. There's lots of options that we can explore today. Good. So total knee replacement is a brilliant operation. It works very well, but I would regard it as a cruel tool to accomplish a task. There's many more options that we can consider first. If you look at the literature, satisfaction from total knee replacements is very variable, and most studies quote 70 to 80% satisfaction, which is actually not brilliant. You're doing a massive operation on someone that carries phenomenal risk, and that level of satisfaction, I think we can do better, essentially. The causes of osteoarthritis the most common cause is primary, which essentially in the orthopedic world or in the medical world means it's unknown, but it probably has a familial or genetic link that we don't know of yet. And then there are secondary causes, and my practice is perhaps slightly more biased towards the secondary causes because of the sports background. And this can be after injury, after osteochondritis dissecans, which was the case today actually, after meniscal surgery, or previous other surgery that hasn't gone well. And the traditional treatment algorithm is primary care, do physiotherapy, painkillers, steroids, walking, and then they come and see someone like me, and I do a knee replacement. The approach I've been using for the last 3 or 4 years now is about trying to save the joint. 5-step approach where total knee replacement is the last resort on the end of that scale at number 5. And I do what I'd want done to my knee essentially. So step 1 is really understanding the problem before trying to fix it. And this sounds really obvious, but you'd be surprised how often that's not taken into account. So it's doing really the basics well. A lot of this can be done in primary care with the GP, with the physiotherapist, or whichever therapist is looking after the patient. And it's about looking at what the patient demands are, what their expectations are, what their limitations are, and what can realistically be achieved. And I hate this, when surgeons say you've got a lot of arthritis, so you need a knee replacement. There's lots of simple measures we know can work. Modifying footwear, targeting muscles for rehabilitation, depending on the particular problem. And some people have a real interest in these areas that can make a difference. In the athletes I treat, a lot of them have arthritis, and we can change their training patterns and look at the sport they're trying to do and how you can adjust it so they can carry on without an operation. Then you've got biological injections and walking aids, perhaps for an older population. So this study, there's multiple studies on this. This was a recent paper. This actually is from not the same paper, but it shows that exercise makes a big difference in pain management, and the physios in this talk will know this, but we know that having good core strength will make a big difference in how you tolerate pain. And this is a study looked at a review that's looked at multiple papers and shown the muscle difference in terms of weakness compared to a normal population in an arthritic group. And you might get weaker, the pain gets worse, and it's a vicious cycle. So trying to break that is really important. Getting on to biological injection therapies, this is a very controversial area in the orthopedic world. I like to use hyaluronic acids quite a lot. It's difficult actually to use that in the NHS these days, but hyaluronic acids, we've done a little study of my practice, and I get on average an improvement of 16 on the Oxford knee score with a course of hyaluronic acid. So that's a good option in certain patient groups. Swollen, what I call wet knees, don't respond very well, but in dry arthritic knees with a period of offloading, that's a really good option. PRP injections, again, I think at the moment PRP is very crude as a tool, but we're learning more, we're getting better at it. Definitely, if you're doing PRP, you should use leukocyte depleted types of PRP for this. For those who are not familiar with PRP, what PRP is I call it a poor man's stem cell treatment, where you take blood off the arm, spin it in the centrifuge, get the platelet layer out, which is essentially rich in various healing factors, and inject that into the knee, almost like a vitamin boost for the knee. I don't believe it causes any regeneration at all, but I think it does help with as an anti-inflammatory effect, and definitely has an effect on pain. And there are other various PRP areas that you can sort of play with, and there are some advances in that area. And then you can get on to really, topics that sound very exciting with the injections, the mesenchymal stromal cell, fat cell injections. And there's some early data published. I'm not fully convinced yet. It's an area where we're thinking of doing a little study on, but that's the next step up from PRP. And then the true stem cell injections, where you take bone from the iliac crest and inject in. Again, the evidence base is very weak. So I think just a cautious note on some of this at this stage. I don't like steroids in the knee at all, and unless it's for a particular reason, such as a fat pad issue. The steroid works very well for ITB. Sometimes it works quite well. But, steroids are really the opposite of biological solutions. We know they're harmful to chondrocytes. They cause chondrotoxicity. They probably soften, well, they do cartilage and bone, so they potentially accelerate wear. And they have a negative effect on the natural synovial fluid. We also know there's a good study from the Hospital of Special Surgery that came out a couple of years ago that the infection rate after a steroid injection goes up, and that can last up to a year. So if you've had a steroid and then you're going to have a joint replacement, you really need to delay that surgery. So I did an audit of my step one, essentially, in my independent practice, and I found my intervention rate dropped really dramatically. And the figures are there, really. I was in 94 patients. I reduced my operating. I wouldn't say I would have operated on all 86%, 86% of those, but certainly I think there was a dramatic reduction in need for intervention. Then we go on to step two, which is really looking at realignment of the joint and preserving the joint. I'm not going to go into too much of the science with this. I'll just use a case example to demonstrate this. So this was a patient I treated a good number of years ago now. I've just got his images, so I always talk about him. I met him, I think, when he was a bit older than this, but he was essentially a 14-year-old boy who tore his ACL, very common problem. So this was a picture of his knee. Unfortunately, we can't be interactive with this talk. This was a picture of his normal knee. Look at the lateral compartment, it looks fine. Pre-surgery, he had confirmation of an ACL rupture. I think the thing that the surgeon missed at the time was this damage here to the growth plate that took place at the same time, increased signal in the lateral femur there, as well as the ACL rupture. So he had an ACL reconstruction, which is quite a reasonable ACL reconstruction with the surgeon who did it. And he used a transtibial technique, which is not the one that I would generally use for an adult, but in children, it's probably acceptable to do that. And so that was a reconstruction, nothing too worrying there. A couple of years later, the child comes back and has already started to develop osteoarthritis of the lateral compartment. So you've got a 17, 18-year-old, he looks like he's 16, 17 here, with established lateral compartment arthritis. This was his alignment. So this is a full leg alignment view. If you draw a line through the center of the hip to the center of the ankle, that typically goes either through the center of the knee or through the inside of the knee slightly. So this boy was a little bit naturally bow-legged on his good knee. And if you draw the same line on the other side, you can see where the line's going. It's not even going through his knee. He's so deformed because of that lateral arthritis. So obviously you can't replace this young man's knee. And so I did quite an unusual operation on him, an osteotomy, both on the top end and the bottom end, essentially opening up the compartment, shifting the pressure to the inside. And this was the correction. That was the before, that was the after. That was about as big as I could go. Ideally, I would have wanted to correct a little bit more and shift him across a little bit more, but he was much better functionally, and he got back to martial arts and did quite well. So this is an example of arthritis, a treatment option for young adult arthritis, and these are the sort of deformities we're talking about. This was a different patient actually, but he had the same thing done. He was quite a tall boy. So osteotomy is a really good option. It went out of favor in the UK. It's never really gone out of fashion in places like Germany. The techniques have got better. We've got much more precise with it. And it's a really good option for young adult arthritis. This is another man who was in his 50s who I've corrected his right knee, this one, and I've subsequently done his other leg as well. And he's back playing tennis and has done very well. Again, was really struggling prior to this to play tennis. So for valgus deformities, the distal femoral osteotomy is really good. For varus deformities, the high tibial osteotomy is very good. If they're really severe valgus, they get a bit of this, and then they get a tibial osteotomy on the other side. So really, young adult knees, you've got to try and preserve the natural knee. That's the key thing. Then we get on to step 3, which is you get into slightly unusual, really complex subspecialty niche areas. which is an area of interest of mine. And I had an example of this at Croydon today, where we had a localized area of arthritis. The rest of the knee was very good. And then you can do various things. You can use fresh allograft transplants. You can transplant menisci. These are quite complex specialist procedures, and they should be seen by the right person. But it is an option, again, in a young adult situation where you're trying to keep the patient's own knee. And then step 4, we get into selective compartment replacement. And this essentially means, do you do a full knee replacement? Do you replace just the bit that's arthritic? And you'll get a very split opinion on this. So I'm just going to share my views with you on this. I am very much biased towards selective compartment replacement. So we've discussed different types of osteoarthritis. The most common is the anteromedial type of osteoarthritis, where the patient points to the inside of the knee and says, I've got pain there. And when you look at the imaging, essentially this part, the inner part of the front middle part of the knee is worn out. The kneecap is fine, the outside is fine, and the back of the inside is also fine because the ACL prevents that bit getting damaged. If you've torn your ACL, the back bit also gets damaged, and then you probably shouldn't do a partial replacement. So it's really important that the ACL is working and that back bit hasn't worn out. In that situation, a partial medial replacement is brilliant. And this is just an example where you've got a lateral compartment that looks perfectly healthy, and then you've got full-blown arthritis, so complete loss of joint space, you've got osteophytes forming, you've got thickening of the bone underneath, and so this is a perfect patient for a partial replacement. And the advantages of partial replacements are multiple, really. The patients definitely recover quicker, and that's a good thing in the short term. The major complication risks, i.e. dying from the operation, getting a deep infection, having a big complication, the Oxford group have shown is 20 times less with a partial than a total. And that's quite a significant difference. Function in a happy partial is much better than function in a happy total. There's been a good study looking at NHS cost on joint replacements, and if more partials were done, there is really strong evidence that that would have a significant reduction in cost as well. If you look at partial knee replacements now, our centre is really moving towards day or 24-hour discharges, and we're getting better and better at that. When Bodine took over, she's really worked phenomenally well on that at the EOC, and there's been a year-on-year improvement in getting our partials moving quicker, not treating them like they're a knee replacement. They're really encouraged to get going quickly. And most of mine in the independent sector go home the next day, so they don't hang around very long. Then we look at kneecap arthritis, and this forms a smaller group of patients. About 10 to 15% of patients have kneecap arthritis, and this is a good picture of this, where on the left side you see the joint space looks normal, and on this side you see the lateral half of the kneecap is worn out, as well as the lateral trochlea. These patients often function very well on flat surfaces. They can walk really good distances on flats. They just struggle going down stairs or down inclined surfaces. Sometimes they start developing instability of the knee. I really try and avoid full knee replacements in this patient group because they're not particularly happy with the full knee replacement. They always lose movement because they usually have a brilliant range of movement. And I, in general, try and avoid any form of replacement in this group. So we go down the treatments we've discussed before. But if those treatments fail, then I will do a kneecap replacement, just replace the patella and the trochlea. And we get decent results from that. And then finally, right at the end of the talk, we'll talk about knee replacements, which once all of those things have been exhausted, it's a good operation, but it certainly shouldn't be our #1 choice. So it's a brilliant operation in the correct patient, but it's not 100% successful. We know the national published figures. We know that our EOC figures as a unit are much better than the national figures. And we've got some, individuals who've got very, very good outcomes. And that's partly because I think we select our patients better. And so we certainly can achieve good outcomes, but I don't think anyone's got 100% success rates because there's so many things that we just can't control with a knee replacement. So valgus deformities are a good example. These patients really should get on and have a knee replacement done sooner rather than later. This is an example of a patient whose deformities really progressed. And when this happens, the bone on the outside collapses and the medial ligament can be stretched and torn. And once the medial ligament is stretched and torn, it's not a straightforward knee replacement anymore. So this is the one group that potentially comes up as a red flag and you want to replace sooner. And the frustration, well, the difficulty with this group is they're not often in a massive amount of pain. They're more struggling with instability, but this is the one time I would probably do a knee replacement sooner rather than later. So then, our centre is invested in robotics. That's an area, I've taken a bit of a lead on, and we've been really working hard on enhanced recovery techniques. We know that to get good results from joint replacement surgery, you need good enhanced recovery techniques, and there's multiple things that we do with our anaesthetic colleagues, using various types of blocks, using special anaesthetics which don't use too much morphine. Some of the surgical techniques that a lot of us have adopted will help with that as well. We know that high volume centres with high volume surgeons tend to get better results, and obviously we are one of those at EOC. We're looking at the potential of robotics, and these are just some images of the robotic planning that takes place. And the big advantage of this is you can really plan to a high degree of accuracy, and the robot essentially will not let you go out of your plan. You've got to plan it properly, and be prepared if the robot's not behaving itself, to go back to doing your normal technique. But I think it adds a lot of value. Our centre also has dedicated specialists for lower volume operations such as revision joints, patellar instability, where I'm one of the dedicated specialists for that. So we have a very organised unit where we make sure the right patient's seen by the right person. Robotics potentially offers an advantage in terms of getting the knee replacement right. It's not a replacement for good rehabilitation and good hard work, though. So this is the approach I use, and as I said, it's a 5-step approach. And the reason I use this approach is it's very patient focused. It minimizes your risk of a poor outcome because you've tried everything you can before replacing someone's knee. It reduces surgical intervention and cost, and my personal data really supports this. But this is a lady who had a robotic partial. This is about 6-8 weeks post-surgery. She's got her full movement back, and has sailed through the operation. Not everyone is like this, but this is just an example of someone with a partial who's doing very well. The role of the therapist, very interesting. Bodine and I talk a lot about this. The published research, as you're all aware, is very mixed, and I'm very cynical of many publications. I think a lot of publications are agenda-driven as opposed to patient-driven. And really, there's been a big agenda to cut physiotherapy. Studies are reporting that group sessions are very good, almost as good as one-to-one. I don't know how many people believe that. I don't. There's published papers showing there's no effective supervised therapy at 6 months post-knee replacement. I personally think rehab should be patient-specific, and I think there's definitely a third of my patients, and I think this gentleman's an example. He had a partial. I don't think he bothered with physiotherapy. He just got on with it, and he was absolutely fine. He got a brilliant range of movement. So there's a third of patients who really don't need too much. They just get on with it. They're highly motivated. Their body just tolerates the operation really well, and they sail through their operation. There's definitely a third or so that do okay, but will do better with physio, and they will get a better outcome. And then I probably should have another little subgroup that do terrible with and without, but there's about a third who really desperately need that regular one-to-one rehabilitation to get a good result. Looking at lots of multiple randomized control trials. Hydrotherapy, I think, has a lot of value. I'm quite keen on hydro. This is, I think, showing a patient of mine who had a knee replacement, and again, can't remember how late down the line he is, but he's had a full knee, sailed through it again, but he was very keen on the hydro, and that for him was a really beneficial thing. And there is some good evidence for hydrotherapy. I think the next 10 years is going to bring a big growth in the biologics. We've seen that starting to happen. And really, the aim is to try and keep what God or nature gave us, whatever we believe in, as opposed to trying to replace it with plastic and metal. But plastic and metal at the right time for the right person is a good option. So a couple of common questions that come up. Red flags in knees, there's not really many. Valgus deformities, I've pointed out, is one time I'd like to see the patient quickly. And obviously, if there's any cancer concerns, I've had a couple of cancers that have come through quite late recently, partly because of delays with COVID, unexplained pain, systemic symptoms with bone pain. Obviously, those need to be flagged up early. When to refer, very difficult. I mean, my view has always been, if a colleague wants me to see a patient, I want to see the patient. I don't really want to give them rules on when they should refer and when they shouldn't refer. They're busy enough. But I think in the world we live in at the moment, there are criteria that we have to look at, and the important things to look at when you're thinking about an intervention is, has function deteriorated? What was this patient doing a year ago? What are they doing now? Is there a clear trend that they're going backwards? Is pain not being controlled with simple painkillers? Has the Oxford knee score dropped and is becoming low? And that's again a subjective interpretation, but once below 20 or so, is it reasonable to start referring at that point? We have set up NHS pathways at Bodine, I'm sure we'll share with you, and these have been done in conjunction with getting it right first time, and they're very integrated into our practices now. And we'd encourage you to use them and be guided by them. Should you do an MRI or ultrasound on an arthritic knee? The answer is no, 99% of the time. The most useful test is a weight-bearing X-ray, AP, lateral, and skyline. If you do those, that should give us the answer in terms of the direction we're heading. If those are completely normal, then I think an MRI is very useful, but otherwise, I wouldn't rush in an MRI every arthritic knee, because MRIs underestimate arthritis and they can often lead you down the wrong path. I used to have a really nice slide in my collection, which I haven't put up today, where I was referred a patient with a lateral meniscal tear, and when we did some standing x-rays, they had such advanced arthritis, and that, you see that all the time. So you really should try and avoid the MRI in patients over the age of 55 unless there's a really clear good reason for it. Ultrasound has limited value. Ultrasound, for me, I don't use it a lot. It's all about the skill of the sonographer with ultrasound and how they interpret it. I don't like it because I'm relying on them and not relying on myself. And so I essentially rely on a report as opposed to some fuzzy lines, because there's not enough information there for me to make a decision. So in terms of diagnostics, ultrasound is very limited from a knee point of view. There's certain things it is quite helpful for, but for arthritis, very limited. So in summary, not every arthritic knee should have a knee replacement. Think about the 5-step approach. Planning treatment based upon individual patients' needs, lifestyle, and risk profile is really important. And you've got to make sure that the intervention is really worth it. And I think all of those, processing those things in your mind regularly, will hopefully improve patient outcomes and satisfaction. Any questions, guys? So the questions can be related to arthritis or sports knee work or patellar instability, anything you like. There's a few that have come through, haven't there?
Yeah, I'll fire away some questions. So Suresh, in MSK services, we see people fail conservative management, and we often try steroid injections to postpone surgical interventions. We don't have access to biological injections. Do you suggest that they should be referred straight to ortho for these patients?
It's a really difficult question to answer, because I think you will hopefully have access to x-rays. And I think you've got to make that decision on x-rays. There are certain patients who never want to have an operation. And that group, if you do a steroid and it works for them, that's fine. You're not doing them any harm. But if you've got a 55, 60-year-old, even a 70-year-old who has got established arthritis, their knee is deteriorating, you've tried all those things, let's take the biologics out of it, but you've tried all those other things, simple painkillers, you've tried physio to build up the strength of the hamstrings, the quads, core muscle groups as well. If all of that has failed, the question is what we're achieving with that steroid. We're going to achieve a short-term relief, but potentially increase that risk of infection in that patient. And so that's a honest discussion you have to have with the patient, because once you've done it, most surgeons will not replace that knee for 6 months. And post-COVID, I had a few of those where the GPs were trying to keep patients going with steroids, and then they came back to have their surgery and we had to cancel all of them. And so if we can avoid the steroids, it's preferable. I don't think you can always avoid it, but just bear it in mind when you're doing it. Hopefully that kind of answers that question.
Right, the next one's from Camila. Do you use different materials for partial replacement versus total? And is the BMI criteria different?
Brilliant question. So BMI and partials is interesting. I do a lot of BMI 45 partial replacements, and they seem to do well. The concern is whether they're going to wear out the other side. But from a technical point of view, if it's a medial arthritis, what I try and do with my partials is we talked about the mechanical axis in one of the talks, in one of the slides earlier. But if they're bow-legged, it means the weight is going through the inside of the knee. So this is where robotics really adds a lot of value. If you can plan your partial and leave them a little bit bow-legged in that situation, and make sure all the weight goes through the partial replacement, or the majority of the weight goes through the partial replacement, then you still end up protecting the good side. So for me, as long as I can achieve that, then I'll do a partial on them. The tricky ones are the patients who've got medial OA, but then have got valgus alignment. They will not do well with a partial. I didn't go into details of that, but they're the ones that tend to do badly with partials, and you should avoid it. In terms of materials, there are two knee partials that most of us at Swelliok use, and they're both very good knees. When we do the robotic, we use an oxinium knee, which is a ceramic coated with a polyethylene, and the science behind that is the wear rate is a lot less. And most of us, when we do, well, there's a few exceptions, most of us, when we do a medial non-robotic, we use something called an Oxford mobile bearing. And again, that's a metal on plastic, but the way that implant's designed, you get a lot less wear. So the concern is always wear. But yeah, whatever materials we use, they seem to work reasonably well. And you can get, I've seen partials going at 18, 20 years doing really well.
And then from Harriet, she asks, what would you advise for lateral compartment OA that's advanced, but there's no deformity?
So Harriet, I think I would go back to the beginning and try all the simple things, the strengthening. I definitely don't do steroids for lateral OA. Certainly, I think they speed up the deterioration of collapse. So try and avoid it again for lateral OA. The options for lateral OA in a young person is a distal femoral osteotomy. So if they're under 50, that's a really good option. If they've failed all those conservative measures. But we can also do lateral unis, and lateral unis are a very, very difficult operation to do well. And I've always done them, but the one big change in my practice since the robotics has come now, if I have a lateral uni, I always do it with robotics. I will never do it without robotics now, because it just adds a level of accuracy that you need for a lateral uni. From a technical point of view, for various reasons, they're much harder to do than a medial uni. So yeah, your options are conservative. If there's no deformity, you don't really need to rush in to do anything, but just make the patient aware that there's a potential for that. And if they're deteriorating, then get on and do something early. But yeah, prior to the deformity, you can do a partial or a distal femoral osteotomy.
Next question is from Daniel. Do you explore patient weight BMI before considering the patient for a partial or a full replacement?
Yeah, so Daniel, the rules on all this seem to be changing quite regularly. At EOC, we did set up about 3 or 4 years ago, Bowden, correct me if I'm wrong, a high BMI user group where we had a dedicated group of surgeons who were focused on the really high BMI patients, and they'd go through a bit more stringent screening. And I think some patients should certainly go through that, particularly when you get into 45, 50 BMIs. And that group's, once you're over 45, 50, you shouldn't have a partial. They should definitely be totals if they have anything. Or whether they should have surgery to address their weight first, which is my preference these days, before they have surgery. But we have got a user group that's dedicated with an interest in the really super high BMI groups. I'm not part of that group. But for an average, let's say a BMI, it also depends on their body build, because I get some men with BMI 40, 42, 43. They've got actually quite nice thin knees, but they've just got a massive belly. Now, those for me, from a knee point of view, are not a big deal. And I treat them just like anyone else. I do the same thing. But then you get some BMIs that are 45 that they're actually quite slim, and their knees are, disproportionately big, and they've got a fair bit of fat on them. And those are the ones I think you need to be a bit more careful with, and I think they're the ones that tend to do worse with partials. So it's not just about BMI, it's looking at that whole patient. So I wouldn't have a cutoff, but if I was being really strict, perhaps cutoff would be around 45 for a uni. Once the BMIs are getting over that, I think there should be some serious discussion about whether they should see a bariatric surgeon first and then have their replacement. But we have some surgeons who have an interest in high BMI surgery, so we tend to refer to those guys.
And next question is from Peter. Will it be advisable to use Ostencil plus injection on patient post-arthroscopy? And would you combine a steroid with Ostencil?
Peter, again, good question. Very patient specific. Ostenil.
Sorry, Ostenil.
I use a lot of Ostenil. It's not really, we don't use it a lot in the NHS, but I'm a big fan of it. In an early degenerative knee, early arthritis, it's a very useful tool, and I've audited my practice over the years, and I've got some really good results with it. Do I use it post arthroscopy? Occasionally, if I use it when I've done an arthroscopy and I've underestimated the arthritis, and I think, oh, I'm a bit worried how well that arthroscopy is going to do. I sometimes use it for that. Post arthroscopy pain, if it's for degeneration, potentially it can add some value. It's a bit of a gray area, but the answer is there's no harm in using it if they're still getting pain and the knee is not swollen. If the knee's swollen, I wouldn't use Ostenil. I don't think it works well at all. Is that okay, Peter? Sorry, last question was, do we use it with steroid? That's the time I use it with steroid. If the knee is swollen and grumbling along, there's synovitis, and I want to use the Ostenil, what I would tend to do is I do the first dose of Ostenil, I do very small dose of steroid, try and drain the knee, put the steroid and the Ostenil in, and then I give them a bit of time, 4 to 6 weeks, and then maybe do another couple of Ostenil on top of that.
There's a question about causes and possible treatments for those who develop an extension lag following surgery, from Hardik.
Causes and possible treatments?
Yeah, for those who develop an extension lag.
So it's one of the, post any knee surgery, that's the surgeon's nightmare, essentially. For me, that's losing extension post knee replacement, post ACL, whatever it is, it's a nightmare. So the key is preventing it, and you've got to try and prevent loss of extension. Now, most surgeons who do a knee replacement will get that knee replacement right. At our centre, they certainly will. But yet, we all have some patients who lose extension. The loss of extension is hard to explain. It is multifactorial, and it can involve what they had pre-surgery. So we know that pre-surgery, there is a tendency for people to move towards that pre-surgery range of movement. So if they were really stiff beforehand, despite the knee replacement getting them straight, they will want to go back into that flex position. This is where I think the physio is really important. And then you get a group that just stiffen up for no real reason. They develop a little bit of patella baja, they throw off a lot of scar tissue, and it's very frustrating for us because it's very hard to get extension back. MUAs don't help with getting extension back, so the only way you can do it once you're beyond 3 months or so is do something, again, it's quite specialist, it's arthroscopic, and I do something called an interval release. And I've done it for some of my colleagues sometimes, as well as myself, when you've lost extension. You go in arthroscopically and release the extensor interval. It's not the nicest operation to do, and the key is avoid it as opposed to try and fix it. So yeah, that's the key, trying to avoid developing that problem. Losing a bit of bend, as long as you pick it up early in the first 3 months, that is usually fixable, but losing extension is really hard.
And a question from Camila, would you ever consider a patient with only mild findings of OA seen on X-ray, but has failed conservative management and reports painful function, but no deformity on the Oxford knee score?
So for me, that's a red flag patient. So if there's disproportionate pain to arthritic findings, it worries me. There's usually things going on with those patients, and you just got to find out what it is. So yes, you can consider them, but I wouldn't, if they've got mild OA, joint replacement should not be considered, because we know from good data that they're going to do badly with a knee replacement. If they've got mild OA and they're in agony, you know, a knee replacement is not the solution for them. Sorry, it's my kids trying to get in. Knee replacement is not the solution for them. So really try and avoid it. You can, rehab, strengthening work, make sure there's no meniscal tear, try the injection. So they're your options. PRP sometimes is quite good in that group. But yeah, no replacement in that group.
I think that's all the questions we've got. So any other questions, anybody? Otherwise, what we will do is we'll send you a feedback questionnaire, and we really highly value your feedback. And you can give us what you'd like us to talk about in future talks. We've got soft tissue knee coming up on the 31st of March, so we'll send that invitation out again if you haven't received it. And if there aren't any other questions, that's brilliant. Thank you very much, Mr. Anand.
Thank you, guys.
And take care. Have a lovely evening, everyone.
Take care. Bye.
Bye.